Welcome everyone to today's webinar, The Future of Pain Management, How to Improve Patient Outcomes with Evidence-Based Medicine. I am Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Dr. Ron Desai is the Director of the Division of Regional Anesthesia, as well as the Director of Rotating and Visiting Residents at Cooper University Healthcare in Camden, New Jersey. He is a recipient of the Bayer Pharmaceutical Excellence Award and also an Assistant Professor of Anesthesiology at the Cooper Medical School of Rowan University. At this time, I'm pleased to turn the floor over to Dr. Desai to begin today's presentation.
Good morning, everyone. Mackenzie, thanks for the very kind words. It's a pleasure to be here to speak with everyone today. So my name is Ron Desai, and I am an anesthesiologist. I spend about 15-20% of my time doing cardiac anesthesia. The other 50 or 60% of my time doing regional anesthesia, that is namely, anesthetics for orthopedic procedures. But what I will tell you is that over the last number of years, really the field of regional anesthesia has really expanded, has really exploded. Classically we think of if you break your wrist, and you need to have surgery, we'll give you a nerve block, and that's going to keep your arm numb. But now we think about it, a little bit more so in that, how else can we control patients' pain who are undergoing big, huge abdominal surgeries? And so we've gotten involved in regional anesthetics for colorectal operations and surgical oncology procedures and breast reconstruction procedures. And really, it's been an exciting time for regional anesthesia as we've expanded from really just peripheral nerve blocks and more so into what we call fascial plane blocks. And then I spend the other 15 or 20% of my time teaching in our medical school. So in little small Camden, New Jersey, we actually have our own 4-year MD medical school that we opened up about 6 or 7 years ago. We're affiliated with Rowan University, one of the state colleges or university programs in New Jersey. We're very, very, very proud of what we've accomplished in Camden. So we've graduated just about our second or our third class now over the past year. And what I do is I facilitate a course called the Active Learning Group. When I was a medical student, we were in a classroom and we'd listen to a lecturer, for 6, 7, 8 hours a day. And the way students learn these days is much different. It's a lot more of self-directed, self-motivated learning. And I'm lucky enough to be a part of facilitating this course that is more of a problem-based learning, case presentation sort of format. And really, one of the most rewarding things I've done in my career up to this point is really being involved in medical student education. So I consider myself fortunate to be involved in that. So that's a little bit about me. I will say Camden has undergone tremendous growth as well. If no one's been through Camden, or if you ever have been to Philadelphia and, you look across the river, there was Camden, and Camden's a different place now. So if you're ever coming out towards the East Coast, I would encourage you to have a stop on, in Camden, and there's a lot of really exciting things happening. So today we are here to talk about enhanced recovery after surgery, improving patient outcomes with evidence-based medicine. We'll try to keep this as interactive as possible. I know the format makes it difficult, but if there are any questions, please let those come in, and I'll let the moderators decide whether or not we can break for that, or if we'll just break at the end for question and answer. So with that, just a little bit of housekeeping. So I am getting paid by Mallinckrodt to present this program to you, but this is 100% educational. There's really no opinion of mine or anyone throughout this program until we get to the protocol I'm going to share with you. But everything is based in the science. Everything is based in evidence-based medicine and is purely in science. So there's really nothing of opinion here. This one we can skip. And so with that, let's go over the objectives for today. So first we'll talk about how there's a lack of standardization in perioperative care, and I think that can negatively impact patient outcomes and ultimately, of course, increase the cost burden of surgical care, right? That's bad. So this lack of standardization can lead to bad outcomes and increase the costs. We'll introduce this concept of enhanced recovery after surgery as a means to help standardize care, and we'll go over some evidence that it actually, in fact, does improve the quality of care and does reduce hospital spend. We'll discuss currently how there's poorly controlled postoperative pain and how that can impact quality of care, and maybe a potential solution for this resides in ERAS protocols. We'll talk about multimodal analgesia in the framework of ERAS, and lastly, we'll talk about some practical and human resource requirements if you're interested in implementing an ERAS protocol. So with that, let's get started. All right, reducing perioperative variability improves outcomes. So you'll hear me say this a number of times over the next 30, 35 minutes, but variability is bad. And let me give you an example of what do I mean by that. So this is done by Dr. Cohen, and this is published in the Annals of Surgery in 2009. And so let's say you have a set of twins, a twin A and a twin B. They are undergoing the exact same surgery and have the exact same comorbidities. One is being done here in Camden, New Jersey, and the other is being done, let's say, in Chicago, Illinois, where I trained at the University of Chicago. Right, so the exact same surgery, exact same comorbidities. What would you expect to have happen? And the answer to that is, well, the exact same thing, right? And so what Cohen is trying to describe is that's not what we're seeing. Before we standardize care, and on the y-axis here is length of stay and incidence and complications, you see wide variability, right? And I'm sure you've all seen this in your own practice. We could take this as, hospital 1 through 6 or surgeon 1 through 6. If we imagine 3 different colorectal surgeons, at your organization who are doing a low anterior resection, why does someone leave in 11 days, and why does someone leave in 9 days, and why does someone leave in 7 days, right? And so what Cohen's describing is that if we standardize care across the continuum, that is the preoperative, intraoperative, and postoperative phases, not only do we see a reduction in length of stay of incidence and complications, but everyone kind of looks the same, right? And so why is this such a big concept? Why am I bringing this up so much? Well, it is that variability is the enemy to quality, right? Variability is the enemy to quality. And I'm going to say that a few more times because I think that's a really important thing. This slide here is simply to depict we spend a lot of money both in the public and private sector on healthcare, and in fact, we of course are the highest in the world. This comes from the Organization for Economic Cooperation and Development, and in 2016, they described that not only was the United States the highest in the world, but it was nearly 2.5 times the average of the other 35 countries polled, and almost a quarter higher, 25% higher than the second highest spending country, which is Switzerland. So of course, there's great room for improvement in terms of our healthcare costs. All right, so let's get into talking about enhanced recovery after surgery. And the question is, can patient outcomes be improved by standardizing perioperative care? And I will tell you the answer to that is definitively yes. And so what do I mean by that? So the goal here really is multidisciplinary care. And so what do I mean? So let's say we have a patient who's undergoing a robotic hysterectomy, okay? A robotic hysterectomy, assuming that's an operation that's happening, across the country. Well, what normally happens? Well, it's current state. Well, current state is, the surgeons get together and they talk about these patients, how can we improve care? How can we do things better in their meetings, their conferences, their tumor board, things like that, right? And then the anesthesia folks, the anesthesiologist, the nurse anesthetist, our residents, fellows, et cetera, we talk together, hey, how can we do things better? How can we take care of our patients and provide better care in our meetings, our morbidity and mortality conferences, and things like that? And then separately, the nurses get together, right? And they talk, hey, how can we improve care? How can we enhance care, right, in their meetings, in their in-services? But when do we get together at the same time and talk together about how we can improve care? And unfortunately, the answer to that is we don't. And so what I would submit to you is that the challenge to improving the quality of surgical care is not discovering new knowledge. Everything I'm about to present to you over the next 30 or 35 minutes, you're going to know all of it. It's all based in science. But it's rather how can we integrate what we already know into practice? To really enhance care is not about learning new things. It's rather how can we work across service lines and integrate better? And so this concept, and that's a really, really important point because the framework for ERAS is about prehabilitation, and it's about infrastructure, and it's about giving patients information and education. It's not about taking out NG tubes and getting them to walk and things like that. It's really about working across service lines and integrating better. And so this concept of enhanced recovery was first described by a surgeon from Denmark. His name was Dr. Kellett. And Dr. Kellett was publishing 2-day, 3-day length of stays after major colorectal operations when the rest of his colleagues across the world were publishing 9-day, 10-day, 11-day length of stays. And so what was so unique about what Dr. Kellett was doing? Well, so the National Health Society in the UK and ultimately in the United States, they sent a multidisciplinary group of folks to uncover what it was that Dr. Kellett was doing. And so what this group learned was that Dr. Kellett assembled a small multidisciplinary team that is of hospitalists and anesthesiologists and surgeons and nurses and therapists and nutritionists who all focused on the small details of enhanced recovery that were evidence-based. And so we're going to get into talking about what these features of enhanced recovery are all about. Before we do that, just in summary, really, these ERAS protocols are these multidisciplinary care pathways, right? So that is nurses and hospitalists and therapists and nutritionists and surgeons and anesthesiologists, right? And they begin from the time that you need to have your colon taken out until you come to the hospital, you have your surgery, you return, you recover in the hospital, and ultimately you get back to your baseline level of function. And some key characteristics of this, of course, is that, number one, very importantly, is they are evidence-based. Equally importantly, they're centered around the patient. Number two, they're designed to reduce the patient's stress response to surgery. And these last two things is really what I think the secret sauce in embracing enhanced recovery is all about. It includes prehabilitation, which we'll talk about in a lot of detail over the next few slides. And the lastly, part here is really this opportunity to manage expectations, getting patients involved in his or her own preoperative preparation and recovery. I really cannot stress this, enough. If you never tell a patient that, they're going to be expected to walk or they're going to have pain, guess what? They're not going to leave the hospital in 3 or 4 days, right? They're going to sit around and do nothing. So it's very important that preoperatively that we not only offer patients information and education, but we also manage expectations and tell them, hey, it's okay if your pain score is a 4 or 5. Our goal is not a 0, 1, or 2. And we'll talk about that in a little bit more detail. But I really can't stress these last two things are not, I really think the secret sauce in enhanced recovery is in these last two things. And of course, there's this integrated continuum that begins when you're at home. Again, you show up in the preoperative area, you have your surgery, you recover at the hospital, and ultimately you get back home to your baseline functioning. All right, so there are 3 phases, of course, to enhanced recovery after surgery protocols. There's a preoperative phase, there's an intraoperative phase, and there's a postoperative phase. And I'll talk about, just about all of these. Some I'll just glance over and some I'll talk about in more detail. Pre-admission counseling, of course, this is our opportunity to give patients information and educate them about what's to come in the perioperative course, and I'll talk about that a little bit further in the next slide. But the other component of pre-admission counseling I want to mention is that this is a great opportunity to consider, can we do a better job in how we test patients preoperatively? Unfortunately, in the United States, there is a huge amount of waste in preoperative testing. That is blood tests and EKGs and consults and chest x-rays and things like that. And so when we put together our first ERAS program about 6 years ago, it was very important to me for us to really improve how we do this, to really reduce waste, be more cost conscious, more financially responsible, and of course there's a component of patient anxiety and fear that's associated with all this testing, right? What's going to come of my results? So we look back from from statements and evidence from the American Society of Anesthesiologists and a number of other surgical societies to really align ourselves with what's best practice. And so anyone who's considering or in the adopting phase of ERAS right now, I'd really strongly want you to think about how can we do a better job in our pre-admission testing program. And so we came up with an automated algorithm based on comorbidities and surgical type and things like that, that really allow our patients to get what's really indicated for them. So just because you're 50 doesn't mean you need an EKG, and just because you're 60 doesn't mean you need a chest X-ray and pulmonary function test, of course, right? So I really want you to think about is an opportunity for us to improve how we do our testing. Bowel preparation, we'll talk about that. We'll talk about carbohydrate loading, the use of pre-medications. Really, by this I mean benzodiazepines more than anything else. I'll get back to that. Of course, in this intraoperative phase, we'll talk about regional anesthetics and multimodal non-opiate analgesics, use of short-acting anesthetics, avoiding fluid overload, using minimally invasive incisions when possible, keeping patients warm, and of course, in this postoperative phase, things like multimodal analgesics, again, prevention of nausea, vomiting, and removal of catheters. Really where I think the most bang for your buck here in this postoperative phase is this concept of early mobilization and early enteral feeding. I know if you can do these two things, it will yield an early discharge for your patient. Now, there's a lot that goes into enabling a patient to, have early mobilization, early enteral feeding, but really that, I think, is the most important component of this postoperative phase. All right, so let's get into talking about the pre-op phase. So, of course, this is when patients are scheduled to have surgery until the time that they arrive into our pre-op holding area. Again, I told you, information management, patient education, secret sauce, and embracing enhanced recovery. So, historically, when patients were scheduled to have surgery until the time they showed up, in the OR to get their colon taken out, they got no information, right? There's no information, there's no packets, there was no literature, there was no education at all. The right side of the slide here, this is done by Dr. Jeff Applebaum from where I trained at the University of Chicago. This is published in Anesthesia and Analgesia in 2003. And what Jeff did was he took all comers and he asked them, hey, did anyone talk to you about the pain you were going to have after your operation? And what he found was that 63% of patients received some education on pain. But that means 37% of patients, or over one-third of patients, got nothing. No education at all about the pain they were going to have. And guess what? Every time we cut someone with a knife and give them pain, what do you think one of the greatest perioperative concerns that patients have? Of course, it's pain, right? The top of the slide here, this is done by Dr. Mitka. This is published in JAMA in 2012. And what Mitka describes is that a third of our patients function at or below a basic level of literacy. Now, I will tell you, this certainly holds true for the population we serve in Camden, New Jersey. And obviously, this can complicate matters, right? When patients have to complete lengthy intake forms or follow preoperative instructions or do dosage calculations or follow written prescriptions and things like that, right? So when you're developing your preoperative materials to give to patients, again, so that we can manage expectations and we can get patients involved in their own preoperative preparation and recovery, it's very important that these materials, they're brief, they're succinct, they're easy to understand. And if I were to poll you and ask you, what group of folks do you think does a really, really poor job at developing materials that are brief and succinct and easy to understand? I suspect the answer that you would all say is a resounding doctors. Right? Doctors do a poor job of doing that. But rather, what group of folks does a really, really great job at developing materials that are brief and succinct and easy to understand? And of course, the answer to that is nurses. So it's very, very important when we're developing these preoperative materials that we identify, we assemble, we employ, we engage the right group of folks to develop these materials, again, so that they are brief and easy to digest and easy to understand. All right, nutritional optimization and carbohydrate loading. These are really two separate things. The carbohydrate loading has to do with the NPO after midnight. So if I were to take a poll right now from all your locations and ask, who is still doing NPO after midnight for patients, who need a surgery the next day, I suspect about 50 would raise their hand. And that's about true for the United States right now. 50% of the hospitals in the U.S. are still doing NPO after midnight. And since 1999, we know that is not ideal. And that was one of the first iterations from the American Society of Anesthesiologists on preoperative fasting guidelines. Patients should be afforded an unlimited quantity of clears up to 2 hours before an operation. Patients should be afforded an unlimited quantity of clears up to 2 hours before an operation. And if they get this unlimited quantity of clears, guess what? There's a reduction in preoperative thirst, anxiety, headache, nausea, and an improvement in patient satisfaction scores. All really great things, right? And if we add a carbohydrate liquid to that preoperative mixture, there's a reduction in perioperative insulin resistance. Also a really terrific thing. Now, unclear which carbohydrate that should be. That could be something maybe as simple as Gatorade or clear apple juice, which are both simple carbohydrates, or something a little bit more sophisticated. What we use is a product called ClearFast, which is a complex carbohydrate. Now, the difference in simple and complex carbohydrates really is this. Simple carbohydrates give you an immediate jolt of energy and then an abrupt fall, essentially in energy, versus complex carbohydrates give you more gradual and sustained release of energy. The other thing about ClearFast is it has a really important amino acid called arginine. And arginine has been shown to reduce surgical site infections and reduce perioperative length of stay. Now, apple juice, clear apple juice, and Gatorade come at a very low cost versus something like ClearFast comes at a higher cost. And the question is, who's going to pay for ClearFast? Should the anesthesiologist, should the surgeon, should the hospital, should the patient? That is something that would need to be worked out. We were fortunate enough to get a grant from our cancer institute, which is MD Anderson Cancer Institute, to help defray the cost of our first, several hundred, bottles of ClearFast. But that is a question. But I do think that this can be accomplished with simple carbohydrates as well, things like Gatorade and clear apple juice. Nutritional optimization. So we serve a population in Camden that is highly morbidly obese, but also highly undernourished. And it was very important for me, to come up with a way to get our patients to stop with the fast food, stop eating the red hots. And so we got our nutritionists involved very, very early and helped our patients come up with financially sensible ways of improving their diet. Okay, and improving their protein intake and things like that. And so there are several JAMA, JAMA meta-analysis suggesting grade A evidence that if you employ both nutritional optimization and carbohydrate loading, there's a reduction in perioperative complications. All right, I could probably poll you as well and ask you, and this is just an example. This is not a direct comparison, but has anyone ever run a marathon or a half a marathon or a 10-miler or a 10K, something like that? I suspect what you do the night before or 2 nights before, I suspect you're probably carb loaded, right? Most of us have a big, heavy pasta dinner or a pasta lunch, right? And what is that? What's the science behind that? Well, there's probably something behind it. We should probably be offering our patients something similarly before their stressful experience like surgery. All right, let's move on. Exercise. So let's say you have Granny. Granny, you have colon cancer. I'm sorry, Granny. Well, what happens to get Granny? Well, she gets sad. She sits on the couch. She essentially gets less strong, right? That is bad. We would all agree, right? I don't think Granny needs to join a gym. I don't think Granny needs to bulk up. I think we just need Granny to move, start to get Granny moving around a little bit more, right? And there's several studies out of Canada suggesting that if you get patients moving for 2 weeks, for the preceding 2 weeks before an operation, they'll do better after their surgery. So how do we quantify this? There's something called the 6-minute walk test. So imagine the room that you're in. You walk from one side of the room to the other side of the room. See how many times you can do that over the course of 6 minutes. If over the 2 weeks preceding your operation you can do that more times, you will do better after your operation. Let me give you some better data. There was a paper published in Anesthesia and Analgesia, again, one of the premier journals for anesthesiologists, in October or November of 2018. And what it sought to look at was those patients who were undergoing major non-cardiac surgery and the 6-minute walk test. And what they found was that those patients who could do the 6-minute walk test had a reduction in perioperative troponin leak compared to patients who could not do the 6-minute walk test. Okay, lastly, bowel preparation as appropriate. Now, I'm not a colorectal surgeon, but what I do know is that some bowel preps are good, some bowel preps are bad. The point here is that you want to standardize it. Have all of your surgeons really doing it the same way. Again, because variability is the enemy to quality. So what ACER would tell you, the American Society of Enhanced Recovery, is that we really shouldn't just be using an osmotic-based bowel prep. If you were going to use a bowel prep, it should be both an osmotic-based one as well as an antibiotic one. What Dr. Kellett would tell you, really who described enhanced recovery to all of us, is that maybe we shouldn't be using a bowel prep at all, and the emerging evidence to us suggests maybe we shouldn't be using a bowel prep at all either. The reason for that is that it's been linked to an increased risk of bowel spillage during an operation. Now, why does that happen? Really unclear, but what we speculate is that when you undergo a bowel prep, your stool turns into liquid, and it's really hard to evacuate all of the liquid stool. And so there's always some remaining liquid stool, and when you go, to have colorectal operations, and you go to transect or cut the gut, the risk of bowel spillage is a little bit higher. So that's what we suspect is happening there. But again, the point behind the bowel prep is whether you use it or don't use it, is try our best to standardize it. Let's move on to the intraoperative phase. This is when patients arrive in the pre-op holding area until they're discharged to the ward. So NG tubes. What do we know about NG tubes? What we know is that those patients who have indwelling NG tubes have an increased risk of pulmonary complications, increased risk of post-op sinusitis, and we really should not be using NG tubes at all. The only patients who deserve to get NG tubes are those that have a known bowel obstruction. So again, outside of that, we really shouldn't be using them. Bowl-directed fluid therapy, I'll come back to that in a moment. That's a super hot topic. Again, this issue of pre-medications, namely benzodiazepines. What we do know is that, especially with our aging population, the use of benzodiazepines causes an increased risk of post-op cognitive dysfunction and post-op delirium, both, of course, which are really bad and can, of course, inhibit our goals of early mobilization, early enteral feeding, and, of course, early discharge. So it's really important to me to come up with a way to standardize how we're going to use pre-medications, namely, again, benzodiazepines, drugs like midazolam and diazepam, things like that. And so what we came up with is that if you were age 70 or greater, or if you have any pre-existing cognitive decline, you got no midazolam, period. All right, so if there's any pre-existing cognitive deficiency, or if you're 70 or greater, you got no midazolam, period. And I would encourage all of your practices to think about how to do that. I work in a group where we're about almost 50 anesthesiologists, we're 100 CRNAs, we're about 25 residents, and we have 10 or 12 student nurse anesthetists, and you can imagine there's a wide variety of practicing styles and skill sets and things like that. So it was really important for me to come up with a way to standardize the use of pre-medications, namely benzodiazepines. Use of short-acting anesthetics, this is pretty intuitive, using things like desflurane, sevoflurane. Of course, you want your patients to be up, you want them to be lucid, you want them to be able to engage in post-op rehabilitation. Avoidance of post-op nausea, vomiting. Of course, there's anesthetic risk factors to nausea, vomiting. There's patient risk factors. There's surgical risk factors. If you're undergoing colorectal operations, you probably have a number of risk factors. So the point here is just use the correct number of multimodal agents to really prevent that from happening and maximize the use of multimodal analgesia. We'll come back to that in a moment. So goal-directed fluid therapy. So the point here is that you don't want to saltwater drown or fluid overload your patient. And if you've been in the perioperative medicine space for a while, you've probably seen a patient get 6, 7, 8 liters of crystalloid solution. And the reason that happens is that clinicians oftentimes view IV fluids as a conduit to giving medications rather than IV fluids being their own medication with their own side effects and complications. And there's, very fancy ways of doing goal-directed fluid therapy that involve arterial lines and stroke volume optimization and pulse pressure variability. And there's also simple ways that just remind your clinicians, hey, don't give too much fluid. And so we started with the fancier way using stroke volume optimization when we were really trying to uncover what does this mean and really how much fluid do patients need, and we didn't really have a good sense of it. But over the last 6 years or so, I think with our core group of folks that's involved in colorectal ERAS, I think most of us all get it, what we're trying to accomplish with goal-directed fluid therapy. And so we do the simple way. And what we've also uncovered is that patients they don't need as much fluid. If you get your patients set up with nutritionists and they improve their diets, and you give them protein supplementation and they get carbohydrate loading and they're moving around more before their operation, and you do it low intensity or no bowel prep and their NPO is only for 2 hours, well, they're not going to need as much fluid. And so the simple way for us looks like this. A patient comes in from home, they come into our holding area, and they get an IV started. And the IV is programmed to a pump, something like an Alaris pump, and that's set to 3 to 6 cc's per kilo per hour. And then that is maintained for the entire perioperative period. And so what does this avoid? Well, this avoids the accidental 1 liter of fluid that's given when you're going from the holding area and patients getting hugs and kisses, and you give them a little bit of pre-medication, and you walk over 3 or 4 or 5 minutes away to the operating room. Or it avoids the other accidental 1 liter of fluid that's given when you're inducing general anesthesia and you're doing a regional anesthetic like a tap block, and you're starting a second IV and putting a urinary catheter in and things like that. So it avoids that kind of thing as well. What just happened here? I'm sorry about that. So the postoperative phase here. Okay, so this is when patients arrive on the ward until they return to baseline function. I'll come back to multimodal analgesia in a minute. So stimulation of gut motility. So when I was a resident, I carried a stethoscope every day. We'd make postoperative rounds. I take my stethoscope, I put it on the belly, and I listen for bowel sounds. Guess what? If we didn't hear bowel sounds, we didn't feed the gut. And what do we know now? What we know now is that if you feed the gut early, the gut wakes up earlier. And what's a great way to get the gut to wake up earlier is, of course, the use of chewing gum. And so what we know about chewing gum is that those patients who tolerate chewing gum have less nausea and a faster return of gut motility. So we start chewing gum in the PACU, and we continue that 3 times a day. Early enteral feeding, you could have, the day before we started our first ERAS program, everyone had NG tubes, no one was being fed, we were listening for bowel sounds, and the next day we just stopped because the evidence suggests we should not be doing that. And so you could have a 5-hour low anterior resection, but in the PACU, we're going to challenge you with clears, and we advance to a full diet on postoperative day number 1. Early mobilization. So there was a study that was done a couple years ago that sought to quantify how much do patients walk on postoperative day number 2 after major non-cardiac surgery. Okay? So we tell patients, walk, right? We write these orders, ambulate 5 times a day, right? But how much are patients actually walking? So the study sought to quantify on post-op day number 2, how much do patients walk? I think the results will surprise you. Despite all these orders to walk, walk the wards, patients walk a grand total of 8 minutes. That's what they found, 8 minutes only. So, if you just tell patients to walk, they're going to get up from bed, they're going to go use the restroom, they're going to get back into bed and turn on their favorite program. So not only do you have to mandate that patients walk, but you've got to quantify how much do patients walk. And there's a wealth of information in the physical therapy literature that if you get patients walking sooner, they leave the hospital sooner. And so we engaged our physical therapists to come up with really the best, early mobilization plan for our patients. And what we thought was the best time or distance for patients to walk was about 1 mile per day. So 1 mile per day is about 15 to 20 minutes, 4 to 5 times per day. Or if you have savvy patients that have a Fitbit or a pedometer, things like that, that is about 2,500 steps. And of course, early removal of drains and catheters, so we don't use any more intraperitoneal drains like JP drains. And of course, we want to get those bladder catheters removed as soon as possible. So how about some data? This is done by Dr. Tim Miller. This is published in Anesthesia and Analgesia in 2004. And this was, conducted where Dr. Miller is at Duke University. And so what they did was they retrospectively looked at 99 patients who underwent open or laparoscopic colorectal operations who received standard conventional perioperative care, okay? Just the normal stuff. They looked at 99 patients retrospectively. And then they implemented their ERAS protocol. And then prospectively, they looked at 142 patients who underwent the exact same surgery, open or minimally invasive colorectal operations, okay? So really good study design, published in a great journal. 99 patients retrospectively analyzed with conventional care, 142 patients analyzed prospectively after ERAS implementation. The primary outcome was postoperative length of stay. There was also a number of secondary endpoints like things like urinary tract infections, morphine equivalents, estimated blood loss, time to first stool, things like that, okay? All right, great study. And so what did they find? What they found, the blue group here is the group that underwent enhanced recovery at Duke, and the green group here was the group that underwent conventional care at Duke. And what they found was that if you were fortunate to be in the ERAS group and underwent either minimally invasive or an open colorectal operation, you were afforded a length of stay difference that was about 2.5 days less. Okay? So if you underwent ERAS at Duke, both minimally invasive and open colorectal operations, your length of stay was almost 2.5 days less. In terms of secondary endpoints, they found that there was less urinary tract infections and a reduction in 30-day readmission rates in the group that underwent ERAS as well. So that's all well and great, but what do ultimately all of our hospital organizations care about is ultimately the cost, right? What does the hospital spend per patient? And what they found, the blue group, again, is the ERAS group, and the green group here is the conventional care group. They found that when they compare both groups, the ERAS group and the conventional care group, they found that the cost per patient were about $2,500 less if you underwent ERAS at Duke. And they found similar degrees of reduction when they adjust for things like age, gender, and both whether it's minimally invasive or open. So you can imagine $2,500, per case, and if you're a busy center that's doing 500, 600 cases, that very quickly gets up into the 7-figure range. All right, so let's shift here into talking about multimodal analgesia. So of course, there's a number of consequences, as it relates to pain, things like patient satisfaction scores and HCAP scores and things like that. But there's a number of, acute physiologic consequences as well to unrelieved pain. So if you have a lot of pain, you have this sympathetic surge, and it causes you to have a fast heart rate and may cause poor wound healing or make you, ischemic. Or if you have a lot of pain and you can't, sleep very well, you can't do your rehab. Or if you have a lot of pain, you get shallow breathing, you develop atelectasis, which of course can lead to pneumonia. Typically when we think of multimodal analgesia, we'll think about it in this intraoperative and postoperative phase. But of course, preoperatively, I really want to emphasize this is our opportunity to manage expectations and tell patients, again, our goals are not a 0, 1, or 2 pain score, but it's rather a 3, 4, or 5. And we want to limit or minimize or eliminate the use of opiate exposure to you, for the following reasons. We want you to be awake. We want you to be lucid. We don't want you to be nauseous. We want you to be able to mobilize. We want you to be able to eat, and we want you to be able to leave the hospital sooner. And again, so I can't stress enough that, multimodal analgesia, the discussion should not just be in the intraoperative and postoperative phase, but also in terms of managing expectations, giving patients education, in this preoperative component. So of course, intraoperatively, we all understand using regional anesthetics and the like, and of course, postoperatively, there's multimodal analgesia, of course, is a big component of that. If you don't use a multimodal analgesic sort of program and you're really just using opiate monotherapy, well, if you get a lot of opioids and you're loopy or you're dizzy, you won't be able to do early mobilization. Or if you get a lot of opiates, could cause you to be nauseous, right? Or if you get a lot of opiates and you develop urinary retention, you're not going to be able to take out the bladder catheters. Or if you get a lot of opiates, you might not be able to do early nutrition, right? So of course, there's a number of adverse events associated with the use of opiate monotherapy. So in the U.S., we think we do a really great job of treating pain, but really we don't. This is a trial that was done 3 times by Drs. Warfield, Jeff Applebaum and TJ Gann. And what they did was they took ambulatory surgery patients and they asked them, how much pain did you have during your inpatient stay? And so if you look towards the right of this bar graph here, you'll see that upwards of 1/3, in fact, in some cases, almost 40% of patients report having severe or extreme pain in the ambulatory setting. And as an anesthesiologist, I really wouldn't expect these findings. I drop my patient off in the PACU, and their pain score is a 0 or a 1, and I think everything's great, and I really wouldn't expect these findings. As anesthesia providers, we do a great job of managing intraoperative and postoperative pain, and these findings really did surprise me. And so why was this study done 3 times? Well, the first time in 1995, Dr. Warfield did this just because she was curious. And then almost 10 years later, Dr. Applebaum did this when there's a lot of interest and a lot of press around pain being the 5th vital sign, right? And then almost 10 years later, Dr. Gann did this when there's a lot of interest in patient satisfaction scores and HCAP scores, and wanted to see if talking about pain, if that might have made a difference. So despite 20 years of talking about pain and thinking about pain care and pain education, right, from 95 to 2014, really nothing's made a difference. Still upwards of 1/3, in some cases almost 40% of patients have severe or extreme pain. And so this is another nice trial done. This is done by Dr. Gann, published in the British Journal of Anesthesia in 2004. What Dr. Gann did was he took 50 patients and he asked them a question. And the question was asked preoperatively, in PACU, 48 hours after surgery, and 14 days after discharge. And the question was this, which I think is very interesting. Would you rather have excellent to outstanding pain relief but have an opioid-related side effect? Something like vomiting, constipation, itchiness, nausea, or dizziness. Right, we know all these. And intuitively, we know why all of these are bad, but I'm going to share with you another reason why all of our hospital organizations care if patients get these. Or would you rather have fair to moderate pain relief but not have an opioid-related side effect? So excellent to outstanding pain relief but have an opioid-related side effect, fair to moderate pain relief but not have an opioid-related side effect. And what you can see for each of these opioid-related side effects, the vast majority of patients chose to have fair to moderate pain relief, but not have an opioid-related side effect. And so this is why all of our organizations care, and this is done by Pizzi. This is published in Pharmacotherapy in 2012. And what Pizzi did was he took about 400 patients who all underwent hip, knee, and spine operations, and they all got opioids. And what they found was that the length of stay for these patients was about 3 days. That's in the blue. But what they found was that if you were to suffer from emesis, unfortunately, your length of stay went up by 3/4 of a day. If you were confused, it went up by a day. And if you were constipated, it went up by almost a day and a half. So, again, other than the obvious reasons why opioid-related side effects are bad, they also tend to lead to an increased length of stay. So, of course, opiate monotherapy has its limitations. There's a number of common adverse events associated with that, things like nausea, and patients itch, and they get sleepy. But there's other more clinically significant things like ileus and bowel obstruction and confusion and delirium, and, of course, more life-threatening adverse events associated with them, things like airway obstruction and respiratory depression and even respiratory arrest. And so this is kind of what I think of in my arsenal when I think of multimodal analgesia. And we'll talk about some of these in detail. But drugs like acetaminophen, alpha-2 agonists, gabapentinoids, local anesthetics, NMDA receptor antagonists, and NSAIDs and steroids. So acetaminophen, of course, and the one thing I want to mention here is that we don't want to just think about these pharmacologic approaches when we think about multimodal analgesia, but there's also non-pharmacologic approaches, things like expectation management, reminding our patients, hey, it's okay that you're going to have a little bit of pain, and stretching and ice and therapy and massage and acupuncture and things like that. So acetaminophen, of course, comes in 3 different formulations. There's an IV formulation, there's an oral formulation, and there's a rectal or suppository formulation. And so, our time together here doesn't really enable us to have, a back and forth interactive discussion. But I would like you to consider, if you're in the perioperative space, what's the best formulation for patients to receive? And let me just give you 2 examples about what I mean by that. So SCIP is the Surgical Care Improvement Project. And so what SCIP says is that we have to give antibiotics 30 to 60 minutes before skin incision. And in the absence of a penicillin allergy, the antibiotic we generally give is a drug called cefazolin, right? So cefazolin, also known as Ansef, which is dispensed intravenously. So why is it that you think SCIP says we should use Ansef? Ansef is the first-generation cephalosporin, which actually can be given orally as well, and it's called Keflex, essentially, when it's given orally. Why does SCIP say give Ansef, don't give Keflex? Well, I think what SCIP has identified is that they want the drug to get to its effector site, to get skin concentrations, and to be as meaningful as possible. And I think they've identified that maybe the IV route might do that better. Let me give you another example of what I mean. Zofran, ondansetron, is a anti-nausea drug, antiemetic that we use routinely as well. That also comes in an oral and a intravenous formulation. And, we routinely give this 15, 20 minutes before the end of a case so that it's peaking when patients get to the recovery room, and hopefully they don't suffer from any nausea or vomiting symptoms or signs. So why is it that we give that 15 or 20 minutes before the end of a case? Why don't we give it orally? Well, again, I think we've recognized as providers that we want the drug to get to its effector site in the most meaningful, time-sensitive way, and maybe giving it intravenously does that. The other thing I'll tell you about acetaminophen is that its pharmacokinetics look entirely different when it's given intravenously compared to when it's given enterally, that is orally or rectally. The bioavailability, the area under the curve, and things like that. So something to consider is that what's the formulation of drugs that were given perioperatively. Alpha-2 agonists, these are drugs like clonidine, dexmedetomidine. Again, outstanding literature supporting their use. They are sympatholytic, they are analgesic, they reduce overall anesthetic requirements, and they reduce opiate consumption. So this is a part of my multimodal arsenal, which is about every operation. Gabapentinoids, these are drugs like Neurontin, which is gabapentin, and Lyrica, which is pregabalin. Again, outstanding literature supporting use that they reduce pain, they reduce opioid consumption. The one thing you need to watch out for, as patients get a little bit older, it also makes them a little bit more sleepy and may necessarily require a dosage adjustment. Local anesthetics, these are drugs like lidocaine, bupivacaine, and liposome bupivacaine. We use all three of these agents as part of our colorectal ERAS program. Lidocaine, of course, can be used as a bolus. It can also be given as a continuous infusion. And we use both bupivacaine and liposome bupivacaine for our regional anesthetics, either for what we call TAP blocks, which is a transverse abdominis plane block, or for a quadratus lumborum block, or for a rector spinae block. So we use those for regional anesthetics. NMDA receptor antagonists, these are drugs like ketamine and magnesium. Again, outstanding literature supporting the use that they reduce pain, they reduce nausea, and they reduce opioid consumption. Now, just because I have all of these drugs up here doesn't mean every single patient needs every single one of these drugs, of course, right? If you have someone who's otherwise opiate naive and who's, 25 years old and is undergoing a relatively simple colorectal operation, maybe you only use one or two of these, right? But if you have a more chronically ill patient who's, older and has sleep apnea and has pulmonary hypertension and is otherwise really opiate sensitive, maybe you do want to use more of these medications. NSAIDs, of course, these are drugs like celecoxib, ketorolac, diclofenac, things like that. Again, outstanding literature supporting the use that they reduce pain, they reduce opioid consumption. The other thing we know is there's probably not one drug that behaves much better than the other. They probably all look very, very similar. And of course, steroids like dexamethasone we use in the context as a antiemetic as well as for pain control. All right, so we're talking about multimodal analgesia. Of course, what does multimodal analgesia mean? It means combining two or more analgesic agents or techniques that act by different mechanisms to provide analgesia. And unless contraindicated, here is really the key. All patients here, all of our patients, receive an around-the-clock, that is a scheduled, not PRN regimen of a non-opioid agent, drugs like NSAIDs, COX inhibitors, and acetaminophen. And this is a very European way of thinking about treating pain, and really a lot of what enhanced recovery is all about is using a non-opioid agent scheduled, using it first and scheduled around the clock before introducing the less safe opioid medications. It's a very backwards thing we do in the United States sometimes. We'll cut someone with a knife, we'll give them pain, and we'll write them for PRN pain meds, right? Or you cut someone with a knife, give them pain, we'll put them on a dilaudid PCA, and when they have breakthrough pain, we'll give them something like ketorolac, right? No, that's backwards, right? We should be using the safer, non-opioid medications first and scheduled around the clock before introducing the less safe opiate medications. And so this comes from the World Health Organization. On the left of the slide is really where some of us are, and on the right is where we really need to be. Well, where are some of us? Well, opiate monotherapy, where if you have a little bit of pain, you get a little bit of opioid. If you have a little bit more pain, we're going to throw more opiate at you. And if you have a ton of pain, you get a ton of opioid, right? Does anyone see a problem with this pain paradigm? Yeah, of course, right? Opioids rank highest, among drugs with frequent adverse events, right? Let me tell you a couple other things that you may or may not know. The Joint Commission has issued a couple of sentinel event alerts over the last few years with the use of opioids. So the first was in August of 2012, and that was called the Safe Use of Opiates in Hospitals. And really, this was intended to avoid accidental opiate overdose. And so what the Joint Commission said was that we should be using both non-pharmacologic and pharmacologic alternatives to opiates, right? Pharmacologic alternatives, of course, are things like NSAIDs, acetaminophen, and COX inhibitors. And, of course, non-pharmacologic alternatives are things like management of expectations, stretching, ice, therapy, things like that, right? So in October of 2015, the Joint Commission came out and issued a second sentinel event alert, and that was called Preventing Falls and Fall-Related Injuries in Hospitals. So every year, hundreds of thousands of patients fall in hospitals, and almost 50% of those falls cause a fall-related injury. And what we know is that if you get a fall-related injury, it may increase, the treatment you receive and may also prolong your hospital length of stay. And so any idea, what I will tell you obviously is, what does one fall-related injury cost a hospital organization? It estimates around $14,000. One fall-related injury estimates to about $14,000. And so the AHRQ, that is the Agency for Healthcare Research and Quality, the Joint Commission, they got together and developed a comprehensive preventative toolkit. And in this toolkit, they identified that one of the greatest risk factors for preventing falls and fall-related injuries in hospitals is, of course, the use of opiates. And so the Joint Commission came out, and this is their pain ladder, where with mild pain, we don't see drugs like opiates. We see things like acetaminophen, NSAIDs, COX inhibitors, plus ion channel blockers, plus local anesthetics, regional anesthetics, things like that. And only when patients suffer from moderate pain, that's when you do all of step one and you add a low dose of opiate. And only when patients have severe pain, we do both step one, step two, and add sustained release opioids and peripheral nerve blocks and things like that. So hopefully what I've been able to impart is that variability is bad, all right? It leads to lower patient quality outcomes, and that by standardizing care, we can improve patient outcomes, we can lower costs, enhanced recovery after surgery protocols are these multimodal, evidence-based, stress-reducing protocols that begin from the time you need to have your surgery, that is that early preoperative, prehabilitation phase, until you recover in the hospital, you recover at home, and they're centered around the patient. There's multiple components, of course, the preoperative, intraoperative, and postoperative phase with a lot of different healthcare providers working in sync. And it's been proven. It's been shown to be efficacious. It improves the patient experience. It improves the provider experience. It improves patient outcome, maybe improves 30-day readmission rates, and ultimately reduces the per-patient spend. And so with that, let's talk a little bit about if you were interested in implementing an ERAS protocol, what do I think is important? Well, the first thing is you got to identify some champions, right? You really need to have all of these folks. You need an anesthesia champion, you need a surgery champion, a nursing champion, and of course an administrative champion. And then you really want to target surgeons who have historically long length of stay and high complication rates. You can start your first ERAS program with bariatrics, but typically the length of stay for a bariatric program is 23 hours, maybe 2 days. And, to implement an ERAS program takes 6 to 12 months or so to really get it up and running. And if you don't have much of a change in your length of stay, you might not find it to be as rewarding. So just some advice, would be maybe target these other fields like colorectal, bladder operations, gyne oncology, liver surgery, spinal operations, thoracic, that historically have long length of stays and high complication rates. And then, there's a checklist that you can get online, and I'll share with you where you can get these that just help keep you organized in terms of, did the patients get their preoperative materials? Were they set up with their nutrition shakes? Did they get their carbohydrate loading? Et cetera, things like that. And then you need to hold your first meeting, really to get administrative commitment to do this. Again, you need to have your surgeon champion, your anesthesiologist champion, your nursing, and your administrators at this first meeting. But it's not just those folks that you need to get, ERAS off the ground. It's really this multidisciplinary group of folks that I told you about previously that you need, and you got to meet frequently, like monthly. Someone. Maybe from library science who can help with gathering literature for you, someone to develop marketing materials for you, and a nutritionist to help with helping patients find financially sensible ways of improving their diet, and of course, someone from research and someone from quality and process improvement, and someone in your anesthesia pre-op clinic and things like that. So there's a huge multidisciplinary team that I think is really important to getting your ERS program off the ground. These are some of the resources that we used that have free protocols, have free literature, free preoperative materials to give to patients. We use the ERAS Society, which is We used ACER, which is acerhq.org, and of course, the American Society of Anesthesiologists Periop Surgical Home website, which is asahq.org/PSH. I didn't really allude to the Periop Surgical Home much. I really do think talking about enhanced recovery and the surgical home are very, very similar. The ASA looks at it a little bit differently. There's a number of financial aspects and OR metrics and throughput issues and things and bundle payments that the surgical home, really directly gets into that enhanced recovery doesn't get into. But conceptually, I think they're both very, very similar. So with that, I only have about 3 or 4 more slides. I wanted to share the protocol that we put together for ERAS, for colorectal ERAS, a few years back. And so again, first thing I think is, I can't stress enough, education, expectation management. Patients are given very basic, easy to read preoperative instructions about what's going to happen. We have them attend a pre-surgical education class with a friend or family member. Again, we don't just want the patient to know what's happening, but we want someone else to be empowered with them to know what's going to happen in the perioperative course. Again, we give them that brochure. We talk to them about preoperative nutrition, smoking cessation, and we set them up with complex carbohydrate shakes. I didn't really get into talking about smoking cessation too much. If there's any questions, I can mention that afterwards. But of course, that's a huge component as well. We talked about standardizing and evidence-based protocols for screening and testing. Of course, anti-infective measures, things like using chlorhexidine wipes and baths, and swabbing for methicillin-resistant Staph aureus. Bowel prep, again, standardizing bowel prep, whether you use one or don't use one. If you do use one, you really, according to ACER, do need to have an antibiotic-based one. Pre-medications, we talked about the use of non-opioid analgesics, using multimodal post-op nausea, vomiting prophylaxis. I'm going to talk about the tap block in a moment, and of course, NPO for only 2 hours, not for midnight. And really the great thing here with the NPO is, for the first case of the morning at 7 a.m., probably doesn't matter too much. There's not a whole lot of folks who are eating or drinking a lot at 4 o'clock in the morning. But for the patient who's scheduled for 3 p.m., it's really what a wonderful thing for them to have some black coffee, some carbonated drinks, some clear apple juice and things like that, up until their surgery, up until 2 hours before their surgery. Of course, risk-reducing measure, we use things like heparin, sequential compression device boots, and of course, antibiotic prophylaxis. Goal-directed fluid therapy, again, that you want to optimize using hemodynamic goals. We use the simple way of doing that. The point here I want to mention just briefly is that really we shouldn't be using urine output, and there's a lot of literature out there suggesting maybe urine output is not a good measure for patients undergoing laparoscopic operations. As we all know, during laparoscopy, there's a reduction of renal blood flow, but also the stress hormone that's released in greatest quantities during operation is typically antidiuretic hormone, and so there's a couple really strong reasons why patients aren't going to make a lot of urine during laparoscopy. So as long as there's some urine in the bladder catheter bag, we're happy with that, but we're really not using urine output as our primary measure for patients' hydration status. Anesthetic optimization, things like using short-acting anesthetics, using multimodal PMV prophylaxis, and of course the minimization of opiates throughout the entire perioperative period. So this is what we use for our multimodal non-opiate analgesics. The first thing is patients get what we call a tap block. That is a transverse abdominis plane block. That block is done using real-time ultrasound guidance, and it is done after patients are asleep, so after inducing general anesthesia, but before incision, before the surgery starts. And so we utilize 4 different points on the abdomen. There's 2 subcostal points and 2 lower abdominal points. And we use an admixture of both bupivacaine and liposomal bupivacaine. And what we found is that by doing it at this point in the surgery, not only do we reduce post-operative opiate requirements, but we're also reducing intraoperative opiate requirements. So, that's why we do the tap block, immediately pre-incision with an admixture of bupivacaine and liposomal bupivacaine. The other component here is that, of course, the onset time for liposomal bupivacaine is somewhere in the 6, 7, 8 hour range, and by adding bupivacaine to that, we're able to exploit the onset time and enjoy the benefits of the regional anesthetic during the operation. Next is all patients get gabapentin. They get this preoperatively, and we carry that off for another 12 doses. The point here is that we're not giving a PRN. It is scheduled around the clock. All patients see celecoxib preoperatively. All patients get acetaminophen in the operating room. We carry that out for another 24 hours intravenously, and then convert to oral acetaminophen. But the point here is that it's scheduled. It is not PRN. And all patients get ketorolac in the OR. Again, we carry that out for another 12 doses. Again, the point here is that it's not PRN. It's scheduled. Glycemic control, all patients are getting a blood sugar and A1C in our pre-admission testing center. This is, of course, to uncover those patients who didn't know they had diabetes, but also to help optimize those patients who knew they had diabetes. The one thing that we're doing differently in terms of glycemic control and colorectal ERAS these days is that not just diabetics, but all of our patients who undergo colorectal operations anticipated to last greater than 2 hours are getting tight glucose control. That is a blood sugar less than 180. The emerging evidence suggests that if you are able to achieve tight glucose control in colorectal surgery patients, they have a reduction in surgical site infections. So, when we first implemented our program, we were just doing it on diabetics, but now we're actually doing it on all patients. So a blood sugar less than 180 is our goal. We check blood sugars every 1 hour throughout the perioperative period. Nausea vomiting, so our multimodal prophylaxis program consists of ondansetron. 15 minutes before the end of a case, we give dexamethasone on induction of general anesthesia, and if there's a strong history, we'll add aprepitant preoperatively. Postoperatively, patients either get ondansetron or they get promethazine as needed. Again, we don't use the NG tubes. We remove the bladder catheters on post-op day number 1, and we're not using intraperitoneal drains anymore. Early feeding, we talked about clear liquids in the PACU. We talked about chewing gum in the PACU. We advanced to a full diet. And, we HEP block all the IVs. There's no more IV fluids on the floor. We didn't want to see patients, having IV poles and Alaris pumps and things like that. I really thought that if we had patients getting maintenance fluids, it was going to inhibit our goals of early mobilization. And so we want to see that our patients are tolerating clears, in the PACU. And so when they go upstairs to the wards, those IV fluids are all HEP blocked. Early mobilization, again, the day before we started the day before we started our colorectal ERS, we had 100% PCAs, and really the next day we just stopped. We still have somewhere a 5 to 7% a failure rate for patients that still require PCAs, but we're super proud that we went from essentially 100% to less than 10%. All meals are out of bed. We talked about ambulation about one mile per day, and ultimately you got to audit how you're doing. This is going to require looking at your metrics, reevaluating your protocol, massaging your protocol. We're lucky enough to have medical students who are, interested in letters of recommendation and things like that. And so they help us uncover, hey, did you get your preoperative materials? Did you chew your gum? Did your Foley come out? Did you get your tap block, things like that, to really understand what our protocol adherence rate is. But this is one of those things that you really do need to audit to see how you're doing and see how you can improve. And so with that, I thank you all very much for your attention. Thank you to Becker. Thank you to Malencroft for the opportunity to speak to you all. And I hope you have a wonderful day. Thanks again.
Great. Well, thank you so much, Dr. Desai, for such an informative, engaging presentation. We'll now go ahead and begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We'll try to get through as many questions as we have time for. The first question is from an audience member who asks, do you have NSAIDs around the clock in your colorectal ERAS protocols?
Great question. Yes. Do we use NSAIDs around the clock for colorectal ERAS? Yes, we do. It's a little bit of effort here to do this because some folks are worried about bleeding, of course. Some are worried about anastomotic leak and anastomotic dehiscence and things like that. But yes, we got bought in for this. We got buy-in from our surgeons for this, and we do use NSAIDs around the clock. Now, let me tell you one thing. We did publish our results early on in the International Journal of Colorectal Diseases, and what we found was the following. We were giving patients Celebrex. We were giving patients Toradol. We were doing fluid restrictions, and all these different things. And what we found was that there was actually an increased risk of acute kidney injury in our patients. Now, so what does that mean? Acute kidney injury means that your creatinine goes up by about 0.3 over the course of 24 hours. So if you start at 0.7, you go up to 1.0. They're both normal values, but yet it still qualifies as acute kidney injury according to the criteria. So what we found was that a larger percent of our patients actually did develop AKI by definition, but everyone came back to normal by day 3. So the question is a great question. I think NSAIDs are definitely indicated in this patient population. I would not use it on top of patients who also require perioperative anticoagulation for, let's say, atrial fibrillation or mechanical, valves. But I do think that there is a strong role for anything we can do to spare opiates.
Perfect. Thank you for elaborating on that. The next question is, Which gabapentinoids do you prefer, gabapentin or pregabalin? Excuse my pronunciation if any of those are incorrect.
Nope, that was perfect. Yep, that was perfect. I couldn't tell you that there's one better than the other. I don't think that there's a lot of science that, gabapentin works better than pregabalin. We use gabapentin. It's a generic product. We're familiar with it. It's been tried. It's been tested. We're familiar with it from cerebrovascular disease patients. We use it in our pain patients as well, our chronic pain patients. A great success. So we're happy with using gabapentin over pregabalin.
Wonderful. And it looks like we have time for just about one more question. Do you have any recommendations on populations to start with when introducing an ERAS program?
Yeah, I mean, that's a great question. So, again, as I alluded to, I think that when you develop an ERAS program, it's a multidisciplinary team that requires these champions to initially spearhead it. And it takes 6 to 9 to 12 months to put a protocol together, to get all the folks together, and to really get started, 6 to 12 months. And so, it's very gratifying that after you start that, you get to see rewards like patients are happier, providers are happier. But it's also great to see things like your length of stay went from 7 days to 5 days. And I think that if you start with a program that's length of stay is already on the lower side, something like breast and breast reconstruction. So, for example, if you have a mastectomy with tissue expanders, patients generally only 23-hour observation, or with bariatric patients, they're typically 23 hours as well. You just might not find it as rewarding if you're not able to really affect the length of stay. Instead, if you target patient populations like colorectal surgery that has historically high length of stay, high complication rates, spine operations, liver operations, hepatobiliary surgery, gynecologic oncology, things like that, I think you just might find it more rewarding after those 6 to 9 to 12 months of effort and developing the protocol. You really enjoy seeing that, wow, our length of stay made a huge difference. Not only patients happier, not only am I happier, not only surgical site infections better, not only is 30-day readmission better, but our length of stay is better as well. So I would target those, in my opinion, those populations first over maybe the breast reconstruction or bariatrics.
Wonderful. Well, that is all the time that we have left for today. I want to thank Dr. Desai for his excellent presentation and Mallinckrodt Pharmaceuticals for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.